may I please call upon Dr. Vijay for the last lecture of the session, which would be titled Recent Trends in Management of Diabetes.
Ladies and gentlemen, this is a very important aspect that we need to understand, that the prevention of cardiovascular disease in diabetes is more important than the treatment, because the disease per se is very aggressive in a diabetes. The cardiovascular disease in diabetes is per se very aggressive and more in women than in men. And we can read here that the total expenditure in America in 2002 was $25 billion in managing chronic complication of diabetes. Out of that, 71% cost was spent on management of cardiovascular disease, which is enough for us to understand that there is a socio-economic burden on the country due to this disease if this is not controlled properly. In India, we don't have the data because our health sector is very unorganized. Most patients pay their bill through their own pocket. We don't have the proper data to tell, but the burden will be more because India being a world capital for diabetes, I am sure socio-economic burden will be more. This is a slide very important, and we can say that proper glycemic control of diabetes is of immense importance in prevention of coronary or cardiovascular disease. Particularly to say so, I have made this slide very simple, that if there is hypoglycemia, the series of biochemical reactions occur that leads to oxidative stress, which causes endothelial dysfunction and enhances the coronary artery disease. Second, on the other side, it leads to inflammation and causes tissue remodeling. So both these leads to enhancement of the cardiovascular disease. My previous speakers have already made points about controlling dyslipidemia caused in diabetes. I would say particularly that glycosylated and oxidized LDL levels are high in dyslipidemia in patients with diabetes. So intense control of the lipid is very important, and next slide is depicting the importance of the proper control of lipid. There is a study done on the huge number of population, heart protection study it is called as, and simvastatin was given. Relative risk reduction was noted from 12% to 31%. That is from diabetes to no diabetes or diabetes with no CVD. It is 31%. Currently we use the Jupiter trial results, which have depicted that rosuvastatin is particularly superior and less toxic as compared to the other statins. So rosuvastatins I support in my practice. I use rosuvastatin regularly in my practice, and also I take myself, because US FDA approved rosuvastatin as for the primary prevention of coronary artery disease. This is the only drug which is approved by US FDA for primary prevention of coronary artery disease. So I recommend that every one of us should use after the age of 30 regularly rosuvastatin in the dose as per suitable to them. This is a study which shows that if you don't control the risk factors in men and women, the coronary cardiovascular disease incidence increases. But they are optimally controlled, you can see the risk reduction is tremendous, and it comes to 5%, 8% like a normal population. So all those who have a risk factor for coronary artery disease, the risk factors are well known. They should control their risk factors properly, particularly the diabetes. Very interesting slide showing if the men have a diabetes, they have 2 times higher risk of cardiovascular disease as compared to the men who don't have a diabetes. Whereas in women, the risk is 3 times more as compared to the women without diabetes. This is a very important data, and earlier speakers have already mentioned that this is very important to control diabetes in women very properly, very aggressively. The mortality ratio also increases. You can see only in diabetes, only risk factor as a diabetes, and all three risk factors in a blue bar. The risk factor of the diabetes alone is higher than the other three risk factors put together. So having a diabetes increases cardiovascular risk tremendously. So prevention becomes a very, very important aspect. And those who are diabetic and have other risk factors should be aggressively treated, and they should be maintain good glycemic control. This is a very interesting slide. It is important to note that the diabetic can be a smoker. So stopping smoking is absolutely mandatory. The slide showing a study done on doctors who were born in 1900 to 1930. And if first slide shows the difference, the curve shows difference of survival of 10 years more life for persons who are non-smokers, whereas as compared to the persons who are smoker. But if they stop the smoking, at the other side shows that if they stop the smoking between the age of 35 to 44, their survival is close to non-smoker. This is an interesting slide. I thought it will be informative for the audience to understand. Earlier speakers have already mentioned details of metabolic syndrome, particularly the waist circumference, particularly is very, very important. The reduction in weight, the obesity reduction is extremely vital in metabolic syndrome. It controls diabetes, it controls blood pressure, it controls everything. So it is important to reduce the weight in metabolic syndrome. If you want to uncouple the risk of cardiovascular disease, modifying the disease by treatment, you have to halt the progression to diabetes, progression of atherosclerosis, hypertensive vascular damage, renal function decline, impairment of cardiac function, and progression of retinopathy. Lifestyle management is very, very important. It is needless to say that physical exercise every day, 40 minutes, brisk walking on a level ground, non-stop is very, very important. On an empty stomach, reduces the cardiovascular risk tremendously, but it has to be regular every day practically. Not 5 days a week like it is mentioned in the literature. I recommend that every day regularly is it gives you absolute fitness, and it controls diabetes and prevent all other risk factors, reduce blood pressure also. So walking, brisk walking 40 minutes every day on a level ground is very, very important. Diet modification is, everybody knows that low fat, low cal diet, no sugar diet for a diabetes, and also high in fiber and high in protein. High in fiber and protein mainly comes from the fruits and the pulses. It's needless to say that. And darker the fruit color, higher it is value of antioxidant value, it's high value in antioxidant. Next slide shows that particularly if you treat blood pressure, if you keep your glycemic control properly to the lower level, if you control and keep the blood pressure at lower level, and if you control LDL, the lifetime atherosclerosis risk is reduced. And treat all the multiple risk factors, start treating them earlier. Earlier you treat, better it is. Investing in your arteries, big or small. Early intervention may well put an end to the epidemic of coronary heart disease that ravaged the world population in 21st or 28th century. By intervention, I mean pharmacological intervention and, if necessary, PCI, that is stent and angioplasty. Thank you very much for your kind attention.
About a psychologist, a diabetologist, exercise specialist, we have all of these on board and are actually being able to achieve such great results with a combined effort in weight management, and probably that is one of the most important things in management of all non-communicable diseases. It's not just diabetes, blood pressure, coronary artery disease, all of them put together. and forms the basis for our management before going on to pharmacotherapy, I don't think we would be wise in just recommending pharmacotherapy. It has to be, integral and a very important part of all of our therapeutics we have in today's state. And finally, whenever we approach any patient with such diseases, it always has to be a multi-pronged approach, like what has been told to us by the Steno trial. We cannot do without lifestyle management, without diet, without exercise, smoking cessation, controlling their LDL cholesterols, blood pressure and blood glucose together. So I usually tell my patients that we have 5 fingers on our hand, and a fist will only be formed when all the 5 fingers are controlled, and I think that's what all of us would agree here. I would like to invite any questions from the house.
I'd like to ask Dr. Bang, which statin you like to use in case of CAD with CKD, chronic kidney disease?
Yeah, this is a very interesting question, and usually it's a challenge for a clinician that when a patient has a CKD or renal dysfunction, the statin that I recommend is also rosuvastatin, but the dose is low and may be alternating.
Well, I think some people say that, nephrologists say that this atorvastatin is better than rosuvastatin.
In my practice, I use rosuvastatin, and I don't see any difference in that.
Any other question?
I'll make one brief statement. Having an exercise physiologist, psychologist, endocrinologist, etc. for that program on the line of Y-weight that you have noted at Medanta, the cost of all these providers adds up beyond comprehension. And I do not know whether in India these institutions only can afford or they are good for the masses. My own feeling would be that if in USA they cannot be true and good to the masses, it cannot be true here. And why am I saying that? Because despite this program at Joslin, which is enormously due to endowment, enormously rich with money, Harvard money, so they have the money, they can do anything they want to do. The country cannot do it, and therefore the Medicare, which is the federal government, Medicare is slightly different. It's our tax money that goes there, and they give out the money for the medical care for people mostly beyond age 65. If they are feeling the pinch of these 4 specialized services and the program, they have suggested the following. Some of the insurance companies, particularly the Blue Cross Blue Shield and Medicare, have gotten together and formulated a plan whereby instead of having the professional specialists coaching for the weight reduction program, non-trained, non-professionals, just like Alcohol Anonymous, getting together the patients themselves and taking care of their obesity and blood sugar. And it has been noted in a very small subset of population that the results are extremely good, and in fact I'm surprised to read and say to you that they are better, they are slightly better. How significant they are in terms of statistical significance, I do not know. They do not know because there are only a few thousand patients so far. It's a very early program. The results are better than the trained professionals giving that program. So that might be a venue for the Indian physicians to pursue than a person sitting in the village, a person sitting in a B-class town, not in Delhi or Bombay or Chennai or Calcutta. If they can formulate that kind of weight reduction program or diabetes program, particularly the weight reduction program, which is a major problem because that's the mother of all diseases, I believe. If that can be controlled, or at least, if not controlled, reduced in size, controlling means you eradicate something like polio you did, you controlled polio, you controlled malaria. So if you can impair the size of the obesity, then I think a major achievement will be there with less cost.
See, I reiterate Dr. Seth's statement. In the city, the people go and spend a lot of money on the weight-losing clinics, VLCC and all this thing, and if this advice is followed, then the job is done.
Okay.
So I compliment all the speakers and let's give them a big hand.
Thank you very much, gentlemen. That brings us to the end of the opening session of day 2.